tibia on the femur is rather placed anteriorly. So, with that fact, meaning that based on the osteopathic terminology, that the patient has a problem with the knee extension. So posterior dysfunction of the tibia on the femur. So the tibia on the femur sitting down rather posteriorly based on the osteopathic terminology, the patient has a difficulty with knee flexion. So technically, the way that you learn this material is that you do the testing of the knee flexion extension. If the patient has an issue with the knee extension, you're going to do the first one. If the patient has an issue with knee flexion, you're going to do the second one, posterior dysfunction of the tibia on the femur. And the next two is that the problem is that the movement of the knee are not necessarily great and affecting the ankle. So you're going to work on addressing the fibular dysfunctions, either anterior or posterior fibular head dysfunction. And the last one is that you're addressing the medial meniscus. So if I want to demonstrate to you, let me have somebody's knee, please. Come on. So what I would like to do is just come down and sit down right here. So for anterior and posterior tibial dysfunction of the femur, which is a problem with the flexion and extension, is that you want to address that with distraction. So let's say somebody who has a problem with bending, you bring it up to the limit of the barrier. You bring up to the limit of the barrier. So let's say that the limit of a barrier of the flexion on him would be, let's say, 80 degrees. Then you apply distraction. This is a posterior dysfunction of the tibia on the femur. So you want to get the Thurst technique is like as if you're doing the anterior drawer. So you do this. So posterior tibial dysfunction of the tibia on the femur. The problem is that knee flexion is limited. You bring it up to the limit of the barrier. You apply the distraction at the limit of the barrier, and then you're going to do your Thurst technique as if you're doing the anterior draw. And then you test the flexion. So anterior tibial dysfunction. So the problem is that the patient cannot extend it. Let's say that this is going to be the amount of the extension that a patient has. So you apply distraction. As I apply distraction, then it's anterior tibial dysfunction. The problem is going to be rather than extension. So you simply do your Thurst technique this way. It's a quick short amplitude thrust. So that you test the neck extension.
Which direction are you
The direction is opposite to the posterior dysfunction. Somebody has anterior tibial dysfunction. The problem is extension. The direction of the movement is as if you're doing the posterior draw. So it's going to be anterior to posterior. Distraction at the limit of the barrier, and then thrust. So you could see that I did one in seated position. I did one in supine position. I could do the same in a seated position. Problem is going to be the anterior tibial dysfunction. The knee extension is limited. You know, now I don't have to support the thigh because the table is supporting his thigh. And so when I want to apply the distraction, it's easier. So as I apply distraction at the limit of the barrier, I'm going to do my quick thrust technique as I'm just whipping something. So that would be the quick thrust technique to gain the knee extension. Yes?
I'm just going to be certain. So for posterior dysfunction, it's
Posterior tibial dysfunction.
for posterior tibial dysfunction, it's the anterior drawer.
Right.
Okay.
With the distraction.
With the distraction.
Right.
Thank you.
You're welcome. So that would be the two techniques to address the tibiofemoral or any complex. So let's look at the anterior fibular dysfunction and a posterior fibular dysfunction.